Good morning everyone. Myself Dr. Devangi Dwivedi, Senior Lecturer in the Department of Oral Pathology and Microbiology, BBDCODS, BBD University. Today I am going to tell you about Kaposi sarcoma. Kaposi sarcoma is a multicentric proliferation of vascular and spindle cell components which was first described in 1872 by Moritz Kaposi, a Hungarian dermatologist. Now considered to be a viral induced or viral associated tumor, it is unclear whether the lesion is a true neoplasm or a simple hyperplasia. This tumor is currently incriminated with HIV/AIDS and its clinical stage depends greatly on the immune status of the patient. Although found predominantly in HIV-infected persons, HIV does not seem to be the direct cause of the tumorous proliferation, and HIV amino acid sequences have not been identified within lesional cells. Coming to the clinical features, Kaposi sarcoma has four major clinical presentations: classic, endemic, immunosuppression associated, and AIDS related. The classic variant is often associated with altered immune states as well as lymphoreticular and other malignancies. Cutaneous multifocal blue-red nodules develop on the lower extremities and slowly increase in size and numbers, with some lesions regressing while new ones are forming on adjacent or distant skin. Oral involvement in this form of the disease is quite unusual, but when it occurs, it does so as soft bluish nodules of the palatal mucosa or gingiva. Lymphadenopathic Kaposi sarcoma is endemic to young African children and presents as a localized or generalized enlargement of lymph node chains, including the cervical nodes. The disease follows a fulminant course with visceral involvement and minimal skin or mucous membrane involvement. In the head and neck region, salivary glands may be affected. This variant does not appear to be HIV related. Transplantation associated Kaposi sarcoma is seen in 1 to 4% of renal transplant patients, usually becoming manifested 1 or 2 years after transplantation. The extent and progression of the disease correlates directly with the loss of cellular immunity of the host. Sarcomatous involvement occurs on the skin as well as internal organs, but oral mucosal lesions are decidedly rare. AIDS-related Kaposi sarcoma. Approximately 40% of homosexual AIDS patients will develop Kaposi sarcoma, often as an early sign of the disease. Affected patients are usually young adults or early middle-aged males. Individual lesions usually occur in many cutaneous locations, especially along lines of cleavage and on the tip of the nose. Oral lesions can also occur on any mucosal surface but have a strong predilection for palatal and gingival mucosa. Early oral mucosal sarcomas are flat and slightly blue, red or purple plaques, either focal or diffuse, may be completely asymptomatic and easily overlooked. With time, lesions become more deeply discolored and surface papules and soft nodules develop or may become exophytic and ulcerated and may bleed, usually remaining less than 2 cm in size. Here you can see the clinical photo for Kaposi sarcoma. Individual lesions may coalesce and occasional patients never develop the nodular variant. Cervical lymph nodes and salivary gland enlargement may also be seen. The patient may have oral candidiasis and AIDS-related gingivitis as well. Other oral sites of Kaposi's sarcoma involvement include the gingiva, tongue, uvula, tonsils, pharynx, and even the trachea. Coming to the histologic features, Kaposi's sarcoma has a similar histopathologic appearance in all of its clinical subtypes. The early lesion patch stage is characterized by proliferation of small veins and capillaries around one or more pre-existing dilated vessels. The slit-like vessels are present around pre-existing blood vessel, skin adnexa, and between collagen fibers. Vessels are lined by plump, mildly atypical endothelial cells. The features resemble granulation tissue. A pronounced mononuclear inflammatory cell infiltrate, including mast cells, scattered erythrocytes, and hemosiderin deposits may be present. There may be a perivascular proliferation of spindle cells, but cellular atypia is minimal. More advanced lesions, plaque stage, are nodular and show increased numbers of small capillaries or dilated vascular channels interspersed with proliferating sheets of sarcomatous or atypical spindle cells, often with large numbers of extravasated erythrocytes and abundant hemosiderin deposition. Slit-like vascular channels without a visible endothelial lining are typically interspersed with the spindle cells. Lesional cells have somewhat enlarged hyperchromatic nuclei with mild to moderate pleomorphism. Mitotic activity is quite variable but is usually minimal. Infiltration by chronic inflammatory cells is also variable. In the nodular stage, all the histologic features are more prominent than plaque stage. Lastly, coming to the treatment, various treatments have been used in oral Kaposi's sarcoma with variable success. Small or localized lesions can be surgically excised with a small surrounding margin of clinically normal tissue, but more recent therapies have concentrated on low-dose irradiation and intralesional chemotherapy. For larger and multifocal lesions, systemic chemotherapy is often effective. That was all. Thank you.